right, good morning, everybody.
Good morning.
Before I get started, did everybody get a little piece of paper?
Yes.
Perfect. Okay. So we'll use that in a minute. Father Larry opened us in prayer, but I want to share a prayer that is just really special to me that I say on a fairly regular basis, and I just want to share it with all of you. So it's called "You Are My Hope." Jesus, at times the thought of my death fills me with fear. In these moments, I throw myself trembling at the foot of your cross. You, the King of the world and Lord of my life, have saved us from death. Your grace is greater than sin, but sometimes I doubt. I worry for my loved ones, especially those who have fallen away from the sacraments or who do not believe. I worry for myself. I am weak and inadequate, and I know that left to my own resources, I could turn from you and reject your gift of salvation. Unite me to you each day. Hold me close in the arms of your eternal love. I want only to be with you. Do not allow me to lose my way. I offer every moment of my life for you to transform and use for my good and that of my loved ones. My joys, my sorrows, every beat of my heart, I give it all to you. May it give glory to your name, Jesus. Take my hand and lead me through life's darkness. You who are my light and the light of the world. Jesus, my way, my truth, and my life, do not ever let me be separated from you. Amen.
Amen.
I'm so glad we are doing this during Lent. This is such a perfect time. We're starting with Ash Wednesday. Remember, you are dust, and to dust you shall return. And then we're ending with the resurrection. So just the hope that is there in Christ in the resurrection. So just as a disclaimer, I'm not going to give anybody specific medical advice of should grandma have had this done, not had this done, okay? Everything and every decision that we make is based on individual specific medical conditions, right? And all of the things that are all wrapped in one. And so this is why it's so important that we have a healthcare decision maker named in our advanced directives. And I know we're going to talk about that, the legal aspects of that next week. So I just want to put that out there. I'm willing to answer any questions, but I can't give you specific medical advice, all right? Just kind of an overview of what we're going to be covering today. So we're going to be talking about what does the end of life look like? What is a natural disease progression, a high intervention death, or a low medical intervention death? And then we're going to talk about organ donation and what the church teaches about that. Okay. Then we'll take a break because that's a lot of stuff to cover. Then the second half, we're going to talk about questions to ask your healthcare team. So when you or a loved one are in the middle of a decision, what kind of things should you be talking about with them? We're going to talk about caregiver support and resources, what are available for you when you are caring for a loved one or when others are going to be caring for you. And then we're going to be talking about grief and redemptive suffering. Okay, woohoo! All right, and then we'll have a good long time for questions and answers at the end. Okay, so if you have questions, just write them down, and I'll get to as many of them as I can at the end. Okay, so okay. I like this. Got to have a little sense of humor if we're talking about this, right? All right. So show of hands, so I know. You can't see what it. Oh, can somebody turn this light off? So what it says is. This guy's here in the living room. He says, "Hi, you can't touch me. I'm here in the living room." And the Grim Reaper says, "Hi, you got me there." So show of hands, who here has been with someone when they died? Okay. Who has been the primary caregiver of someone who has died? Okay. And who has never been near someone who's died ever? And this is a new experience. Okay, good. I just like to know where everybody's coming from. So, all right, so you have that piece of paper. I would like everybody to just take a couple minutes. I want you to write down, what is it, give me 3 to 5 things that you're most afraid of when it comes to the end of life. Things that you are scared about? The end of your life or someone else's? And I promise I'm not gonna make you share all your fears in a small group, okay? We all have things we're afraid of about death in the end of our life. That's natural. God gave us a God-given fear, right? So I want everybody to share, what is it that's scared? For me, loss of control. Because I have control issues. So, for me, one of the things I'm worried about is lack of control. Okay. What are some things other people are afraid of? Pain. Pain. Okay. Anything? Yeah.
Making a wrong decision and then regretting it.
Sorry, I failed penmanship in Catholic school, just in case anyone's wondering. Yes?
That the doctors are telling you the right thing. A lot of times, one doctor will say one thing and another doctor will say another.
So contradicting information.
And you have to figure out which is right for you.
Okay, so discernment.
Yeah.
Okay. Anybody else? Yes?
Dying alone.
Making sure you receive last rites?
Right.
Okay. That's a good one. Purgatory.
Put hell on there too.
We'll just throw a little fire over here. Yes.
Yeah, making sure that my family can handle all the arrangements associated with my death, funeral, wills,
Okay, so
etc.
family final arrangements, okay. No pressure of spelling in front of as many people, right? Anybody else? Yes.
That my children will know what they can do if we were in a situation where I required medical attention, or, you know, they had to make those difficult decisions, that they would be prepared.
So trusting others to make their own decisions?
And fortifying them.
Okay. Okay, anybody else?
Being there even though there isn't anything to do anymore.
Okay, so just being, yeah. lack of a to-do list, right? Okay. Yes,
I don't think this was said, but not having anyone to fight for me.
okay, not having an advocate.
Crises, an
Yeah.
advocate, yeah.
Okay, anybody else? Right, that's a really good list. So hopefully, in hearing kind of the fears that are in the room, this represents some of the things that have been going through your own mind too, okay? So even if you didn't say it out loud, that it's still there. We all have these natural fears. We're gonna discuss and address a lot of these today, so you're in the right place, all right? I'll push this back out of the way, they're still there. All right, turn this back on. All right, maybe, there it goes. All right. So we need to identify our fears, because if we don't identify them, we can't address them or do anything about them, right? So it's good to stop and take time to think about these things. And Jesus has handled this. He knows, he's gone through all the fears and all the pain that we are ever going to go through in life. So in John, he says, do not let your hearts be troubled. Believe in God. Believe also in me. In my Father's house, there are many dwelling places, and the plumbing won't ever need to be repaired. If it were not so, would I have told you that I go to prepare a place for you? And if I go and prepare a place for you, I will come again and will take you to myself. So where I am, you will also be. Again, that hope of heaven is just incredible, right? So that hope of heaven gives us the ability to go through the dying process. The flip side, we can only get to heaven by going through the dying process, okay? So rejoice in the Lord always. I'll tell you, this is like my favorite scripture verse of all time, okay? So rejoice in the Lord always, not just when things are good, not when things are going perfectly, or I'm not having any body aches or pain, or I'm not tired, I'm not dying, but always, okay? Do not be anxious about anything, but in everything, so this again includes the end of our life, by prayer and petition, make your requests known to God. And then the peace of Christ, which surpasses all understanding, will guard your hearts and your minds in Christ Jesus. And that's just something to keep in mind as we go through all of this and all of the logistics and the nuts and bolts, okay? So what I'm doing today is we're gonna talk about, last week we covered a lot of the theology and the higher up stuff. And now we're taking that and kind of, here's where the rubber hits the road, okay? Here's where we take this faith that God has blessed us with, and we get to put it into practice and figure out how do we do this at the end of our life or the end of a loved one's life, okay? So our human dignity, every single one of us has been created by God, and that's where our dignity comes from. God has entrusted each of us with the intellect to cooperate with his will, okay? He has used our will and our knowledge to be able to do things like discover penicillin, right? 100 years ago, we all would be dead by now because of an infection of some kind, right? Okay? He made someone figure out that, where we get pain medication from. There's a chemotherapy called Taxol that's used for a lot of people with breast cancer. It comes from the bark of a yew tree. I just want to know who looked at that and said, I know we could cure cancer with that tree. God uses our natural curiosity and our brains, and he entrusted mankind to come up with things that help different diseases. It blows my mind. So God works through doctors, through pharmacists, through, drug investigators, nurses, everybody, in order to help continue to bring about his will. And it's incredible that he allows us to cooperate with him like that. So we've been given the gift of all sorts of different medical advances, but that doesn't mean we're always required to use all of them, okay? And so we're gonna talk about that too, right? And both science and faith are grounded in respect for both truth and freedom. Does that make sense? Okay, so we have the freedom to choose. God gives us our free will, and we can use our reason and our logic in addition to our emotions to make decisions. Okay? All right, so last week, I know Dr. Nolan covered this, the different basic ethical principles. So we have, they're long words, but beneficence, which means to do good, okay? So we're gonna try to do something and we're attempting to do a good thing. Non-maleficence is kind of the flip side of that same coin, where we're going to try and do no harm. So say you've got cancer, and you've got a giant tumor, I'm going to have to harm you by cutting open your abdomen to get this tumor out, okay? But my intent is the good of being able to remove the tumor and help your cancer and help you be better. That makes sense? Okay, so we're doing something that will harm you, but the goal is to do the good, okay? So then autonomy, the ability to make our own decisions. This includes informed consent, which is a huge thing. We need to be able to have all the information in order to make the right decisions. So that means asking doctors kind of probing questions. What does this mean, you know? And then justice, making the best use of the available resources. We're very blessed. We live in an urban area where, you know, a 20-minute drive is going to take us to any number of hospitals, right? So we're in a very different situation than, say, somebody who's in third world Africa, where in order to go get that surgery, it's a 5-hour drive, and you know, you have to spend 3 years worth of your income to pay for the surgery, right? So we're in a very different situation than other people. But again, this is why we need a healthcare decision maker to help us take all the pieces of the puzzle and put them together so that we can come up with the best answer at the time for our specific situation. So, times when you've seen these different principles play out. So, autonomy, informed consent. Right now, we're going through a situation in July. My father-in-law was diagnosed with a gallbladder duct cancer. He's 82. He was relatively unhealthy, had polio, and you know, lives a relatively sedentary lifestyle. They offered him 2 different surgery, well, one surgery, which in the process of trying to get that surgery, found out that he didn't pass his cardiac stress test. So now he needs bypass surgery in order to have the original surgery for the cancer. Okay, that's a lot for somebody who's 82 and already not overly healthy. He was given, you know, information by the physicians. Unfortunately for him, he's in a family with 5 nurses. So we all gave him all of the information of what those procedures would entail, which was much more than what the doctor shared with him. And at the end of that, he said, you know what, there's a good chance I'm gonna die. I wanna die fighting. And so, yes, I understand that there's a chance I could die on the table, but I could die in 7 days from complications. I could die from within the first 30 days of complications. But that's what I want to do. And you know, I'm so at peace with that because I know he made an informed decision based on all of the information. So the more questions you ask, the more peace that gives to those that you love, okay? Doesn't mean that you're doubting the physician or you're doubting their expertise. You're just asking more questions to get more pieces of the puzzle, okay? So those are all good things. Trust your nurses, ask them. Sorry, as a nurse, I think that that's what you should do.
100%. 100%.
So ask them. They have an area of expertise. Ask all of the people on your healthcare team all of these questions that you have, okay? Distributive justice. Again, we have a limited number of resources, and we see this play out daily. If you go to the emergency room, somebody who has a stroke is going to go in before somebody who has a sprained wrist, right? That makes sense, because the person with the sprained wrist can wait a little bit. A person who's in the middle of having an active stroke probably shouldn't wait, okay? So that resource is time and expertise. Does that make sense? Okay, so we do this all the time, you know, even just when you're prioritizing your life at home. Okay, I have these 5 things to do, but this one's is the most urgent, so I'm gonna go do that one first, Okay, so we do this all the time in our daily basis, and it plays out in healthcare too. All right, big words. Okay, so euthanasia and Bene Morticia. Euthanasia, the actual origin of it, it means easy death. So this is what is considered, you know, we hear this in the world, you know, having death with dignity, right? Our version of dignity at the end of life is so different than euthanasia, okay? So euthanasia is an action or an omission of an action that itself or by intention causes death in order to alleviate suffering, okay? So an action or a deliberate inaction where the intention is to cause death, okay? And the cause is a big word, the intention and cause, big difference. Bene Morticia, it means to die well, okay? So that means allowing a natural death to occur. That is in no way euthanasia, because that is allowing the natural process at the end of our life to end, okay? That is, so yes, it's the same action of say, I'm not going to choose to be put on a ventilator or have CPR, but it is absolutely morally and ethically acceptable, okay? So John Paul II wrote a very long declaration on euthanasia. You can Google it, I included the link in the resources for you. And he said, it may happen that by reason of prolonged and barely tolerable pain for deeply personal or other reasons, people may be led to believe that they can legitimately ask for death or to obtain it for others. So that would be euthanasia. I've been put in that situation before. I've had patients ask me, can you please just end this for me? Or family members, what can you do to make this go faster? You know what? I can't. That's not my timing, that's God's timing. But what are they asking for in that moment? They're asking to end the suffering, okay? Not necessarily to end life, but to end the suffering. So where is that suffering come from? How can we support the person in that, okay? So they need access to good medical care, good symptom management, pain relief, emotional, spiritual support. They do not need judgment, they don't need anger, they don't need condemnation, they need love, okay? So we support them by giving them the medical help that they need, by giving them love and support and resources to be able to handle the cross that they've been given in that moment, okay? So the other thing John Paul II said is life is a gift of God, and on the other hand, death is unavoidable, right? How many of us in this room are gonna die? All of us, right? Okay, unless Jesus comes again and sometime before then, there's a really good chance we're dying, okay? So it's unavoidable. It is necessary, therefore, that we, without in any way hastening the hour of our death, should be able to accept it with full responsibility and full dignity. So just as every other responsibility we have in life, so parenthood, our job, everything, we're supposed to accept that with the full responsibility that we've been given, we also need to accept the end of our life with full responsibility and with full dignity. So I had a patient named Larry. He was amazing. He was a former state trooper, big, burly guy. He was 6'2", and then there's me at 4'11", so we look very entertaining together. And he had a brain tumor called a glioblastoma, and I took care of him for a number of weeks. The unit that I work on is a symptom management unit, so we're kind of like the ER or the ICU for hospice. So most of the people that come to me are with us for between 5 and 7 days is kind of our average. He was the exception and wound up on our unit for about 6 weeks. So because of his glioblastoma, it had affected the part of his brain where you speak. So he wasn't able to talk at all, but he absolutely understood everything that we were saying to him and others were saying to him. So without getting too graphic, he lost use of his bowel and bladder. or control of it. So we just named it the Great Poop Incident of 2017, and I'll just leave it at that. But for people who are supportive of euthanasia, they would say his dignity is gone, right? This guy used to be a police officer, and now, you know, he can't even control himself. This is how humiliating. I would never want to be in that situation. I had the privilege of being able to serve him and care for him and love him in that moment, right? And I got to clean him up and help him just make it through that and the next day. But again, people who are supportive of euthanasia would have ended his life, preferably right before that moment, right? Well, 3 weeks later, his sister, who he had not spoken with for over 40 years, and his wife had been calling for months to say, please come see him, he wants to see you, please, you know. She finally decided she was ready to come see him. And although he couldn't talk to her, they had a resolution in their relationship. And I think that is dignity. Allowing those relationships to heal, to just be. He was able to be present with her and accept that even just that tentative step that she was able to make. He was able to be present for that. And what a beauty that is, and what a gift. And I would hate for him to, or anybody else, to have been robbed for that. People ask me, you know, working in hospice, do you see miracles? And I say, well, I don't necessarily see, you know, the person that I'm caring for get up and walk out fully cured, you know, and live for another 20 years. But I see miracles every single day. I see relationships healed. I see pain alleviated. I see emotional suffering. I see people grow in their relationships with God every single day. So it is such a beautiful, beautiful time in life that I just can't emphasize enough just the joy and the peace that comes in those last days and weeks of a person's life. I'm not saying it's not hard and that it's not painful, because it is. Yes?
Last week I was talking about how there's so much grace, it's almost palpable when those two worlds are touching there as a person approaches death. Maybe this is something you're already going to talk about, but I would love to hear your experience. You're in that cusp, zone there where the two worlds are touching. What's that like for you? Can you feel that sense of supernatural divine choreography all around this stuff?
Yes, absolutely. So the question was, am I able to kind of be present and get a sense of that supernatural divine choreography? Absolutely. Do I experience it like at a profound level every single day? No, because it's, I've got all the real world, unfortunately, like Medicare requirements and stuff I also have to pay attention to. If I didn't have to do any documentation, I would probably be able to be in that space all the time. But absolutely, at this stage in life, I say people have one foot in this world and one foot in the next. So we're bridging the gap. And so you get to see, people, I'll talk about this in a minute, just, being able to have experiences of seeing loved ones who have gone before us, and to know that's where they're heading, and the surety that comes with that. Are they always able to express that verbally to us? Not always. But the peace and the beauty of someone when they are just especially in that last day or two, like their face is so completely relaxed and their arms, have you ever, after you've got, I don't know if you've gotten a massage, but just afterwards and you just lay there and they're done and the person leaves and you're like, I don't want to move. Yeah. They're like, take your time. I'm like, I could still be here in 3 hours. Yeah. But I see that kind of peace and relaxation on people all the time. So I had a family member who, her mom was there, and her mom was one of those ladies who said the rosary every day. She's like, Mom, all the time. She was doing this. And, I think they had 6 kids. And not all the kids were practicing Catholics. Some of them were other religions. Some of them had no faith at all. But after her mom died, she came out into the hallway and she just looked at me bewildered. And she goes, I had no idea death could be so beautiful. There is a beauty in it. It's a gift. It's hard, it's painful, but it's also beautiful. So, all right. Thanks, Father Larry, for that tangent. All right. Okay, sorry for the super busy slide. This is a lot of words, but Dr. Nolan covered this last week. I'm going to go again into really specific details because it's just how to make these decisions and how to give Catholics guidance on how to make these decisions for the end of life. Okay, so number 56. A person has a moral obligation to use ordinary or proportionate means of preserving his or her life. Proportionate means are those that in the judgment of the patient offer reasonable hope of benefit and do not entail an excessive burden or impose excessive expense on the family or the community. So I love that we have our own personal autonomy, but also the benefit of the community is taken into account. So ordinary and proportional means, what does that mean, right? So that means things that we would do to ordinarily care for a person, okay? Making sure that we are keeping them, our basics, food, clothing, shelter, basic comfort, medical care, okay? So making sure you're getting food and water and things like that, as long as you're able to take that in. Though that is a moral obligation we have for ourselves and for others, okay? Now here's the flip side. A person may forego extraordinary or disproportionate means of preserving life. So what does that mean? Disproportionate means are those that in the patient's judgment do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or community. So again, this is going to be individual to each person, to each community. So again, us in this urban metropolitan area versus third world Zimbabwe, right? So when we have, there's all of these medical procedures. So say, a number of years ago, 2019, my daughter was in a really bad car accident, okay? She's 19 years old, physically very healthy. She gets T-boned by a shuttle bus. Thank you, God, for side curtain airbags. She needs to have surgery, and so they need to put her on a ventilator. They need to put in a tracheostomy because they had to put her face back together, okay? So she needed a breathing tube in order to be able to breathe while they did this surgery and for a few days later to make sure that she could keep breathing, okay? It would be immoral for me to say, no, we're not going to do this surgery in this situation because she's still young, she's very healthy, she has a very good chance of recovery. It's immoral to not do that, okay? If someone, say my father-in-law, who is, 81, has a cancer diagnosis and is already, has cardiac issues and things like that, if he's in a car accident, we've got all these other things going on, that may not be a moral decision, okay? So it's the exact same intervention. In some situations, it is morally acceptable, in others, it is not. And again, this is why we need to have a healthcare decision maker for us listed and communicating our wishes to them so that we know ahead of time and they can help make the best decisions possible, okay? So in principle, there is an obligation to provide patients with food and water, including medically assisted nutrition and hydration, for those who cannot take food orally. This obligation extends to patients in chronic and presumably irreversible conditions, like a persistent vegetative state, who can reasonably be expected to live indefinitely if they're given such care. So I'm sure most of you remember the Terry Schiavo case, about 20 years ago. They had court orders, everything, to prevent people from even giving her, even moistening her lips and her tongue and giving her any water. That's morally unacceptable, okay? Those are ordinary means that we can do to make someone more comfortable. In her case, she was dying not from an underlying condition, but from dehydration and starvation, okay? So that is morally unacceptable. We need to provide nutrition and hydration in these persistent vegetative state situations. Now, overall, that is less than 1% of people, okay? It's very rare. It's, and there's all sorts of criteria to say someone is in a persistent vegetative state. So there's, again, lots of doctors involved by the time you get to that point. But just that is part of our Catholic moral teaching, okay? So again, the flip side, medically assisted nutrition and hydration become morally optional when they cannot be reasonably expected to prolong life, or when they would be excessively burdensome to the patient, or would cause significant physical discomfort, for example, resulting from complications of their use. For instance, as a patient draws close to inevitable death from a terminal or fatal condition, certain measures to provide nutrition and hydration may become excessively burdensome, therefore not obligatory, in light of their very limited ability to prolong life or prolong comfort. What does that mean? So, if we are already dying of a terminal condition such as heart failure, lung disease, cancer, something along those lines, and our body is already starting to shut down because we are less conscious, less aware, less able to eat things, we are not required to place a feeding tube in these tube feedings or do IV nutrition hydration, because our body is already naturally telling us, I can't do this anymore. I'm already starting to shut down, okay? The complications of putting in, having a procedure done to place a feeding tube and to start those feedings is another burden that we're putting on a body that's already shutting down, okay? The manifestations of using artificial nutrition, again, I'm a nurse, I'm trying not to be too graphic, but when your body is shutting things down and you can no longer absorb that nutrition, we have a natural anorexia, okay, when we're hungry, when we're dying, the body's shutting down. So the gut stops working, which means that everything you put in on the front end comes out the back end, okay? It's not an enjoyable experience. It causes a lot of moisture. At that point, people also are usually not able to get out of bed and walk, which means that they're laying down the whole time, increasing their risk of pressure ulcers, okay? So that means that you've got moisture, you've got lack of mobility, lack of nutrition, you wind up with these open sores that then are painful and require more intervention in order to be cared for. So in general, adding this one intervention causes a whole cascade of other problems because the body is no longer able to do it, to handle that food anymore. So, when, in that case, we take the lead of our body, okay? Again, we're already starting to get more tired. We're starting to get more sleepy. We're not hungry. Think back to the last time you had a really bad cold or the flu. Were you talking a lot? No. You were sleeping a lot. Were you hungry? Not usually. Were you thirsty? No. You drank because you know it's the right thing to do, but not because you wanted to. You just wanted to go back to sleep, okay? People who are at the end of their life are so much sicker than someone who has a really bad cold or the flu, okay? So it's called a natural anorexia. They're not hungry, okay? So I just want everyone to know that, it is not something that the person who's dying is struggling with. It's not bothering them at all. All right.
Can I ask a quick question?
Sure. Yep.
How do you account medically for this experience where people have that surge towards the end? I hear it so often.
I'll get to that later. Yeah, it's in there. Yes.
So, for people who are maybe in their 60s or 70s, they live a full life, maybe 70s, and for some reason or another, they're in a coma, so they're not awake. But they might not really care about living anymore. And they find a directive that says it's okay to remove nutrition and hydration. Does the church consider that to be morally wrong? I mean, if keeping nutritional hydration there would keep them alive for another 10 years in a coma, would it be wrong to remove that at that point for them?
Okay, so the question is, if a person who is in their 70s or 80s has lived a long life, but they're in a coma, would it be medically wrong to remove their nutrition and hydration if they could live for another 10 years? So my answer to that would be, depends on what the underlying condition is, okay? If they have an underlying condition that is terminal, that's a chronic progressive terminal condition and death is imminent anyway, then no, it would not be morally wrong. If they could live for another 10 years, then that would be considered a persistent vegetative state, and it would be morally wrong to remove it. So it depends on what the underlying condition is that they'd be dying from. So, does that help? Sort of, yeah. Again, it depends on what the underlying condition is. Okay. Any other questions? Yes?
I was going to say, Dr. when you were saying, if we cause a death, obviously that's morally permissible, but if we allow the natural process to happen, that of course is permissible. And all of these distinctions that you're making, I think in the light of faith, it's perfectly logical to us. But much of the world, and a lot of people in the medical field are not viewing life through the lens of faith. And I'm just wondering if you see, they consider this hair splitting. We don't, but they do.
Mm-hmm.
And I'm wondering if you have to intervene all the time to try to shed light of what you understand because of faith. Because I feel like there's an effort there's so much threatening about overpopulation, about how we don't have enough young people in the workforce to support the older people who are retiring and aging. And I personally am not in the medical field, and I've seen several instances where I believe medical personnel have hastened the death of people needlessly.
So I think when we're in situations where we're concerned that the medical community is hastening the death of someone, that's where those ethics committees and ethics panels come in. So we can always ask for and request an ethics review in any situation, okay? So I served on the ethics committee at St. Agnes for many years, and we had lots of those where, anybody can call an ethics review. A family member, a physician, anybody on the treatment team can call those. And so that's where we, bring up those issues and talk about it. And a lot of it also is educating our medical community as to what Catholic beliefs are. And also, again, the flip side is being open to, we live in a society where death is the enemy, right? And the medical community says, we've got to treat as long as possible. There are times when, even though the intervention is available, the benefit of it is going to be so nil that the burden outweighs the benefit. And so we need to look at those and see, does the benefit outweigh the burden, or does the burden outweigh the benefit? And again, that's where an ethics committee is really good at being able to kind of get into the nuances of all of that. So, okay, so I talked about that. I'm going the wrong direction. Sorry, everybody. Hold on. This talk just got 4 hours long. All right. So, the overview of the dying process. Okay. There's immediate, short-term, we're going to die quickly things. Okay. So things like car accident, fatal heart attack, stroke, homicide, suicide, drug overdoses. In general, those are a very short, something catastrophic happens and a person dies instantly or in a matter of hours or days. That's not going to be most of our experience. Most people have things such as heart disease, lung diseases, cancer, kidney disease, dementia. Those are, the majority of us will go through this. So this is the leading causes of death for 2021. It's still too early in 2023 to get last year's numbers. So this is the most recent. So heart disease, cancer, are long-term diseases, stroke, respiratory diseases, Alzheimer's, diabetes, kidney. So all of the majority of us are going to die due to long-term illnesses. Okay, so just big graph to show that's the experience that most of us are going to have, most of our loved ones will have. Okay, another super busy slide. All right, this is overall disease trajectories. So what does an average death process look like? Okay, so the top one is for people in general who have cancer. Okay, so you're going along with your life, you're getting your treatment, things are going relatively okay, you're having a little decline, but overall it's not bad. At some point we say people fall off the cancer cliff. Okay, so all of a sudden, boom. And then you have a short, relatively short period of a sharp decline, and then you have the very end of life period, okay, and then death. So we have, again, kind of diagnosis and death, okay? So that's what kind of in general cancer death will look like, their end of life will look like. This is for things like respiratory diseases, heart disease, things like that, okay? So you're going along, maybe, you already had some decline in order to be able to get diagnosed with it and to have, maybe you already had a heart attack and now you're dealing with heart failure. And you're kind of having a slow decline, and then, you got fluid overload and now you're wound up in the hospital. So your function status goes down to here. Well, then you get into the hospital, they take the extra fluid off, they give you extra steroids, they do the things that help you feel better. And so you come up, and you get back up there, but you're still not as good as you were over here, or before you went in the hospital. You still have had a little bit of a decline. And then you got another little decline, and then respiratory, COPD exacerbation, and I wind up needing steroids, and I'm back in the hospital again, and I got better. But I'm still not where I was there, okay? And the reason I'm showing this is because this keeps happening over and over and over again. And what I want people to see, I usually take care of people when they're here, okay? And people tell me, well, but they were fine last week. Well, yeah, you're right, they were fine last week, but let's compare it to where they were 2 years ago, okay? And so we're still going down and down and down. Again, we're having periods where we get back up and things are getting better, but we're overall still not at the same level that we were a year ago, 2 years ago. So a lot of times when we're looking at end-of-life decisions, we have to look not just at the last 2 or 3 weeks, but look at the last 6 months, look at the last year, look at the last 2 years, and see the overall pattern of illness. Does that make sense? This is overall this is for like dementia and Alzheimer's, various dementia, Parkinson's, things like that. So again, you've already had a dwindling down from your function in the first place, and again, it's just more a slow, gradual path that eventually, you have more and more decline. Now, I will say with dementia, that is starting to change, because as all the new drugs that have been coming out to treat dementia, we're actually starting to see more people with dementia that are actually starting to look more like the cancer trajectory than the original dementia trajectory. So it's going to be interesting to see how that changes over the next 10, 15 years. So those are the things that interest me on my days off. Okay, this is what's called the palliative performance scale. None of you actually need to remember this information, but again, it just tells you here overall, where are we functionally, and where are we going, okay? So if you're in this room, you're probably at a 70% or better, okay? Because it means you were able to get up, get dressed, hopefully shower sometime in the last 3 days. That you're able to, get your food and drink, you're able to do all of those things yourself or with a little bit of help, okay? Again, I usually take care of people who are at a 50% or less, most of the time 30% or less. So this is saying you're mainly sitting or lying down or mostly in bed. You have considerable extensive disease. You're not able to do any activities, that you're needing assistance in just about everything. Not eating much and either fully alert or having periods or all completely confused, again, depending on the disease process. Okay? And then again, as we get closer and closer and closer to death, our ability to do things gets less and less over time, okay? So again, this is another way that we can kind of quantify the decline that we see over time. So this is I'm guessing what a lot of you want to know. What do I expect, right? What is it that's going to happen? So we do everything in ranges in hospice and palliative care. So we say somebody has months to years to live, weeks to months, days to weeks, hours to days, or minutes to hours, okay? So in the weeks to months, before you die, in general, you're sleeping more. And again, this is for a low medical intervention death, okay? This is just natural disease progression. You're sleeping more, eating and drinking not as much. You are talking less, which my husband will be thrilled about for me. More withdrawal, decreased socialization. So, you're not going out to parties, you're not, maybe your one outing a week is going to mass, okay? Or going to, the family dinner, but you don't have the energy to do the other things anymore. You need more assistance with your ADLs, or your activities of daily living. So dressing, bathing, showering, all that stuff. Increased pain, more aches and pains than what you used to have because you're not moving as much, you're not doing as much, and as Parks and Rec says, everything hurts and I'm dying, okay? Vision-like experiences, and again, this is, people who we got one foot in this world, 1 foot in the next, okay? So these are all very common experiences, and these can all be, they're all just very normal. So if you're taking care of somebody who, used to be very outgoing and used to be at, 10 activities a week minimum, and they're only going to 2 now, that's okay, right? It's normal, it's expected, okay? They are reserving their energy for the things that are most important to them. So let them do that, okay? All right, what to expect in the hours to days before death. So, people have very little to no oral intake. We call it sips and bites. So you're just eating a little bit, you're not eating a lot, you're just not hungry. So when it comes to food and nutrition, it's not just about food. It's about the entire meal experience. So think about it, when you're eating a meal with your family, does everybody just sit there and eat the food for nourishment? No, we're talking, we're sharing stories, we're talking about our lives, we're talking about the things that are important to us, or about just that random crazy thing that happened today, right? So when you have someone who's at the end of their life and is physically no longer hungry, a great way to support them is to continue to involve them in the meal process. And as that goes from being able to join you at the kitchen table, now maybe they were sleeping at 5 when you had dinner, but at 7:30 they woke up. The family that's there and around can gather again at the table, okay? They're not hungry. So instead of putting the entire meal on a big plate, you can take a salad plate or a coffee saucer and put those 2 or 3 bites that they're probably gonna eat, put that on a plate and let them eat that and go, wow, I'm still hungry, can you get me something else? Okay, it's the number of people that have told me, like when we just bring their tray that comes from the kitchen, they're like, oh my gosh, that is so much food, I could never eat that. Whereas if we take the food off the tray and we put it on the little tiny plate, and they're like, oh, that looks really good, So it's something that's so simple. They are not going to eat what we're eating today, okay, whether we should or not. So let them be part of that family meal experience. When the person can no longer go to the kitchen to eat anymore, bring the chairs to the bedroom, or bring the chairs to the living room, and everybody sit and enjoy the meal with them. So that's just a really easy thing to do to help continue that. The food and nutrition to us just means love, right? You love them with food, right? Somebody's hurting, you bring them more food. Bring them not just the physical nutrition, bring them the food that is the love of family and community. Changes to temperature and the color of the skin. So as our brain as things start to shut down, we notice the functions in the brain go from the frontal cortex, which is our executive function, the higher level thinking, and it kind of goes back to the brainstem, okay? So it kind of shuts down from the front to the back. So the brainstem does all of our things that happen every day that we don't think about. So controlling our temperature. Think about a newborn, right? Newborns, you gotta put a hat on them because they can't, they get cold real easy, whatever, you gotta wrap them in a blanket. Same thing, our body temperature goes all wonky, okay? So in general, it starts at the bottom, the feet, the extremities, legs, and works its way up. The person themselves, if their feet are really cold and ice cold, that doesn't mean they need socks or an extra blanket. It means their body has said, I don't need to worry about my legs anymore, I'm not using them. I'm gonna focus my energy up here to like my heart, my lungs, my brain, okay? It doesn't bother them, they do not feel cold, okay? So you're not having to, you don't need to turn the thermostat up to 95 and make everybody miserable. Their feet are cold because the blood's not circulating there anymore, but they don't feel cold, okay? Same thing with the hands, the same thing happens. And that will come and go over the course of the few days that this is happening. Changes in the color of the skin, it's the medical term for it is called mottling. And it is just like a redness on the palms of the hands, the feet, and then it turns into like a bluish purple color, okay? Totally, I say it's not normal, but it's normal for this process, okay? Incontinence of both bowel and bladder, very normal, expected. Confusion, disorientation. There's a term called terminal restlessness, terminal agitation. Any of you ever had restless leg syndrome, or you're laying in bed and you can't sit still and you're trying to sleep and you can't? Okay. Agitation, or this terminal agitation, terminal restlessness, is just as disconcerting of a symptom as pain. Okay, so it needs to be treated the same way you would treat pain. If the person cannot lay still and they're trying to get up and go, they're uncomfortable in their own skin, and we want to be able to help them be more relaxed and more calm. Okay? Decreased urine output. As the kidneys start to shut down, the body stops being able to excrete, and so people stop making urine. People become minimally responsive or unconscious completely. So we say respond to verbal stimuli. So, when you start talking and they responds to tactile, so touch. So if you say their name, they don't move, but if you touch them, they'll wake up. Or pain. So like if you're repositioning somebody and that's when they wake up. Okay? So those different levels of consciousness people will go through. And in general, people go in that, from the weeks to days to hours, they are awake for, say, 14 hours a day, down to awake for 10 hours a day, down to awake for 4 hours a day, to 2 hours a day, to 5 minutes at a time, maybe 2 or 3 times a day, okay? That is the natural disease process, okay? So, let's see, congestion. So, when we have, at the end of our life, let me go back. Every morning, when you wake up, you do this without thinking. You probably don't even notice you do it. You wake up, you just kind of, feel everything, make sure everything still moves. But you clear your throat, okay? We don't even think about doing it. And it's just the phlegm that collects while we're sleeping and collects in the back of our throat. When people are in those last hours to days of their life, their cough reflex is not strong enough anymore for them to be able to clear that. And so we have what's called tracheal congestion, okay? And so has anybody heard the term the death rattle or heard it? Okay, so that's what that is. That's all it is. The person is not drowning in their own, their lungs aren't filling with fluid. It's literally a little bit of mucus at the back of their throat, okay? And if they could cough it and clear it, it'd be fine and it would go away, but they can't, okay? Some people, we can suction it and get that cleared out. I had that happen the other day. I just, this guy, I could hear him down the hall, and I went in and suctioned him and he was better, okay? So sometimes you can fix it, sometimes you can't, okay? And when you're in that situation, that's a great question to ask the hospice nurse, how do I handle this, okay? Breathing pattern changes. When we hit breathing pattern changes, usually we're in the last 24 to 48 hours of life, okay? So people's breathing will go from, regular, normal is 16 to 20 breaths a minute. When people will go from that to, 30 to 40 breaths a minute, that's like they're running a marathon while laying in bed, So we can use medication to be able to bring that breathing rate down to kind of the normal level. So that is normal. We have people that have apnea. So like sleep apnea, people, use a CPAP for sleep apnea, where you have a pause in your breathing that lasts 5, 10, 15, I see them as long as 25, 30 seconds on a regular basis. Doesn't mean that's their last breath, okay? It means that that's the breathing pattern they're in. So they may have a 30-second period of apnea, and then have another 30 or 40 seconds of breathing at a regular rate, and then they'll have another period of apnea, and then another, however long, and that can happen for hours or days. I will say, as a family member or a loved one, that is excruciating, okay? Know that that is a normal end-of-life breathing pattern that can happen for hours or days. And we say, in general, the faster we see these changes, the shorter the timeline. The longer it takes to see these changes, the longer the timeline. Okay, so hopefully that helps, that if you're seeing all of these changes happen over the course of a week, it's still gonna be a little while. If you're seeing them happen over the course of a 12-hour period, it's a very short, we're at, just minutes to hours, okay? As a hospice nurse in general, the way we tell people we've gone from hours to days to minutes to hours is when we can no longer feel pulses in someone's wrists, okay? So we don't feel them in the feet for a long time, but when you can no longer feel pulses in the wrist is when we usually say we're in a minutes to hours, and that's usually when, I'm in an inpatient facility, that's when we'd call the family and say it's time for you guys to come in, okay? So that's a broad overview, okay? Before is your arm having trouble, or are you asking a question?
It's a little bit of both.
Okay. We're almost done and almost ready for a break, everybody.
Vomiting. I saw somebody an hour from their death vomit, and it's upsetting, to people to see them suddenly sit up in bed out of a comatose state and projectile vomit, and then they go right back to the pillow and they're a mess, and we clean them up, but it's kind of upsetting for the people around the table, around the bed. I mean, is that something that you ever see happen, or?
So again, just depends on the disease process. So I have seen that happen. In general, it happens with cancers that have caused a blockage in the abdomen. But that happens more in a high medical intervention death than a low, in the hospice setting where I'm at. Again, because of all the extra fluid that people have on board. So, all right, I'm going to share with you real quick a video. This is from one of my patients, and if I can get it to work in here, and I can't, so let me figure out how to get it to the. Okay, yeah, if you can get me to that, that'd be lovely. While Santa fixes technology's not my thing. I'm really good at being a nurse, not technology. So, anyway, so this is Camille. She was one of my patients who was able to be with us for a couple months, and she's very special and close to my heart. She was a photography professor, and my daughter is now going to school as a photographer, so she actually met with my daughter and talked to her about being a photographer and what it's like. And it was really cool because at the end of her life, she's not able to be a professor anymore, but she's still able to mentor someone who's young. And it was a lovely experience. Because of her, my daughter's going out to Arizona because she talked to her about how the background of what you're shooting has to be what you love. So if you love seeing the beach, you should not go to school in Kentucky. If you love the mountains, you shouldn't go to school in Florida. So she's going to school in Arizona. Thanks, Camille. But she's a very special lady, and she did a video for Gilchrist, where I work, for marketing. And so, she and her family have given permission for us to be able to share this. So, again, it's only a minute long, but it gives you an idea of, just from someone who's dying, here is her perspective of what it's like.
It went away. Give me a minute.
And it went away. All right. We can do that after break if you want, because I think that was Camille's story. And you're going to see this is where I work, and you're going to see some of my coworkers. So just, I love these people. All right.
What I just enjoy is I felt like taken care of. They know what you need sometimes, even when you don't know what you need. There's a team of people who know what they're doing. There's doctors here, there's the nurses, or they know who to get or who to call, or you're on call. You're taken care of here. It's not just a warm, fuzzy place, it's a fill everything from the page movie, but it also knows how to do its job. And that is also very comforting. It's about living your best life towards the end of your life. It's exactly what they say, they promise they want to do, is what they're doing. Gilchrist has made it possible for me to make my life the possibilities I wanted to be in these circumstances. There's no guarantee. It's definitely giving me the tools and the hope and the support that I've got a pretty good chance of hitting the mark that I want to hit. And it's due to that.
There's my plug for Gilchrist. Nope. Okay, there we go. Perfect. Except that you can see
speaker
everything.
view is up here.
All right. Told you, not good at technology. So that just makes me smile because Camille was just such an amazing lady, and I am so privileged that I got a chance to get to know her. I think it's probably one of my favorite parts about being a hospice nurse is I get to meet people that I would never have gotten to meet otherwise. So I've gotten to meet, people like her. I got to take care of a lady who, I see this, 92-year-old lady, tiny person in the bed. She was a trapeze artist for Barnum and Bailey, and there's a picture of her on top of an elephant in the room. Like, that's so cool! So, anyway, so it's one of the amazing perks of my job. So,
All right,
okay.
give me a minute.
All right.
Keep talking.
Okay. We'll do the opening prayer that requires no technology for the second half of this. How's this sound? So, here is, again, I have this awesome book that a friend gave me called, it's a Memento Mori book. So it has all sorts of prayers for kind of end of life, preparing for end of life, praying for the dying. So this is a prayer to entrust our anxiety to Mary, and this is from St. Aloysius Gonzaga, so a lot of people are familiar with him. So he was able to have a vision of when he was going to die, and so he spent the rest of his life praying that God would prepare him for his death. So this just says, "O Holy Mary, my Queen, I commend myself, body and soul, to your merciful care today and every day, especially at the hour of my death. To you I entrust all my anxieties and sufferings, my life and the end of my life, that through your intercession all my actions may be directed and disposed of according to the will of your Son, Jesus Christ. Amen." So if you're ever looking for a good book, I'm a fan.
You got it, Sandra.
I think
I got it?
Yep, you got it. That's
Okay.
good. Perfect. Thank you. All right.
The books again, title.
It is called Memento Mori, Prayers on the Last Things. Amazon, right? Is that right? Yeah. All right, so talking about a high intervention death versus a low medical intervention death, okay? Prayers on the last things. To get it one foot here. Okay, so in the medical world, we say, okay, yes, I want this one thing, but it means that there's a whole lot of other things that happen because of it. Okay, so yes, I decided I want CPR. What does that mean? What comes after that? So you're going to be in the ICU environment, lots of IVs hooked up to you. We'll use a ventilator, which is a breathing machine that breathes for you and regulates the amount of oxygen coming in and out of your lungs. It involves, typically, because they need to make sure your kidneys are functioning okay, a urinary catheter, so fun. I personally am a fan of them, but not everybody is. Constant blood pressure and temperature monitoring, all that. So usually in the ICU environment, your vitals are taken between as short as every 15 minutes to as long as every hour. There's a large care team. You've got all the specialists and everybody are all in one place, which is convenient, but it also means you've got a lot of people giving you lots of information, sometimes conflicted. A lot of noise. There's so much noise. So I worked in the hospital for 20 years, and when I started working at Gilchrist, I, about 3 months later, went back to go visit my coworkers on the old unit, and I walked in and I was shocked at how loud it was. Because to me, that was normal. But I was thinking, oh my gosh, there's alarms going off and there's just constant everything. So lots of noise, lots of support from, the ICU social workers to palliative care team to the hospital chaplain. So there's a big, so you got a lot of interventions, but there's also a lot of support in that space. ICUs typically have limited visiting hours. So, if the change of shift at 7 in the morning, 7 at night, usually everybody's kicked out for that time period. And then again, anytime a procedure is being done, there's just not enough space in those rooms for the number of people that need to be involved in whatever's going on. And being in an ICU environment is necessary for organ donation, and I'm going to get to that in a little bit. Okay, so just that's my stuff on the high intervention desk. Okay. This was my excuse to use a picture of George Clooney in anything I'm doing. What are your chances of surviving CPR if you're already in the hospital and you deteriorate to the point you need CPR? What are your thoughts? What guess? Better. Okay. Huh?
Way better.
Way better. Okay. Anybody else? Okay. 70%? Okay. So, if you're in the hospital, your chances of, if you're already sick and you're in the hospital, your chances of surviving initially cardiac CPR is 24.8%, which is a lot lower than we see in the movies and on TV, right? Thus George Clooney. So, the chances that if you have CPR in the hospital because you were already sick and needed CPR, and that you're going to survive to actually be discharged from the hospital is only 12.6%. The chances that you're going to survive to discharge with no complications is 0. Very different than what the movies say, right? And, again, you're watching ER or Grey's Anatomy or one of those shows, they do CPR, and 10 minutes later, the person's sitting up and having a great conversation with you, okay? That's not reality, okay? So a lot of people survive that initial CPR attempt, but then their condition continues to decline, okay? Common complications, neurological decline, even though it's done, the person is not cognitively aware in the way that they had been afterwards. And then what we call a functional status decline. Remember I told you that PPS chart, right, of where you were and, what you're able to do? Not everybody, but almost everybody has a decline in that, and they're not going to be in the same place as they were beforehand. Okay, so not fun numbers, but reality. There's a journal article listing if anybody wants. I didn't pull those numbers out of a hat. So, okay, a low medical intervention death. So yes, Wendy.
I'm sorry, what exactly do you mean by CPR? Is that when you use the paddles?
Okay, good question. So CPR it's a combination of things. Okay, so it's cardiopulmonary resuscitation. So cardio is heart, pulmonary is lungs. So that is the chest compressions. Okay, it includes breathing for you, so resuscitating using usually one of the ambo bags is what they're called, ambu, and then adding the defibrillation, which is the shocking. Okay, so doing all of those things together. Typically, the way a code runs, Marianne knows better, she's done way more codes than I have, but it's using all of those things together along with a lot of medications, epinephrine, atropine, all sorts of things, in order to try to restart the heart. Okay? So, low medical intervention death. So, meaning, again, we're allowing natural death to occur, the bene morticia. Okay, so typically that happens at a home or in a residential care facility. So if your loved one or yourself are already in an assisted living or a skilled nursing facility, it would be taking place there. There's support from a hospice team, and every hospice, it's required by Medicare that they have a 24/7 support line available that is staffed by nurses to answer questions anytime, day or night. Oral meds are given by the family in order to be able to control any symptoms that the person is having. So any pain, any shortness of breath, things like that are managed by the family at home. And then the family is responsible for the day-to-day caregiving of the person, okay? So preparing their food, cleaning, doing their laundry, cleaning, turning the sheets, changing sheets, changing them. The hospice nurse and hospice aide will come in for about an hour, hour and a half a day, or multiple days a week, depending upon the acuity of the person. And, so they will provide some of that support, but they are not there 24/7. That is the family's responsibility, okay? And so these are things that, if you are, say you're 92 and you have your own set of health problems, and your 94-year-old spouse is there, and all your kids live in different states, and you don't have support, those are things that you need to take into account, that maybe this isn't going to be the best fit for me, and what do I need to do? And so we're going to get to that stuff also, okay? So we kind of started talking about some of these things in practical terms. So a ventilator, that is a machine that breathes for us when we're not able to breathe ourselves, okay? Typically a ventilator requires both, a short-term breathing tube placement. If we need to be on the ventilator for more than, a few days or a few weeks, then a tracheostomy is placed, which is a more permanent breathing tube that goes through the neck into the windpipe. A pacemaker or an AICD. Pacemaker is something that's implanted in the chest that helps your heart beat for people who have heart failure and different different heart conditions, irregular heartbeats, etc. So that just will, if your heart's not beating right, it'll, send a little pulse to tell your heart, time to do your thing. An AICD is a implanted defibrillator. So basically when, you see on TV they go clear, it'll do that from inside your chest if your heart goes into what's called a shockable rhythm. So, your heart can do all sorts of wonky things. And when it goes into one of the wonkies, it'll shock you, okay? That's an official medical term, wonky. So, AICDs can be turned off at the end of life, because as part of the natural, again, in those last minutes to hour stage, our heart does naturally go through these different rhythms. And so we don't want someone to be being shocked in the last minutes of their life. That doesn't sound comfortable. And so anyway, all of the staff, both in hospitals and in home hospice, we have abilities, we know how to do that. So we can walk you through that if you have it. If you ever get a pacemaker or an AICD, they will drill this into you, but you're going to get a card that will have who made the pacemaker and or the AICD, and the phone number to contact them. Give that to your medical staff so that we can contact them in order to turn it off, okay? If not, we have all their numbers and we can figure it out by making a bunch of phone calls, because eventually we'll find the one that you got. Dialysis. Dialysis is when your kidneys shut down and you're no longer working and are no longer able to filter the toxins out of your bloodstream, okay? So basically dialysis, they pull your blood out, they run it through an artificial kidney, and basically that does what your kidneys would do for you, and then the blood gets put back in, okay? And that is, you would know better than I would, 3 to 4 hours, 3 times a week?
She does peritoneal, so
Oh,
it's
okay.
a 17-hour cycle.
The 17-hour cycle, yeah, so that can be done at home, where you put the fluid into the abdomen, and then it stays there, and the toxins go out that way through osmosis, and then it goes out. So you can do it both that way or the hemodialysis, which is where you use the blood and you go to a dialysis center, okay? Feeding tube, we kind of covered that a little bit earlier. So again, it can be through the nose down into the stomach, is a temporary one, and that can be used for a few days to a week or two. If we decide that someone's going to be on tube feedings long term, then we place what's called a PEG tube, which is where it goes through the stomach, or it goes through the skin into the stomach, and it goes, and the tube just feeds you directly into your stomach. Okay. A DNR, do not resuscitate, or a MOLST form. So a do not resuscitate is where you tell, in your advance directive, you say, if I have a terminal condition, I don't want you to do CPR, and then the physician writes an order. So if you're in the hospital, you have to have a physician's order that says do not resuscitate. In hospitals, you will usually get an extra ID band that says DNR, so that when everybody runs in, because somebody called, we call calling a code, when everybody runs in, somebody's gonna go, wait, they have a DNR bracelet. Okay, so even if no one in the room knew you because, you know, your heart stopped when you're walking in the middle of the hallway, they would know, okay, we're not gonna do CPR, stop, hold on, that's not what they wanted, okay? A MOLST form is a 2-page form that is, again, it's a physician order. If you're ever leaving a hospital and being transferred to another facility, even home, you have a MOLST form if you do not want to be resuscitated. And it has more specific questions about, like, if you're in pain or you're having a major problem, do you want to be transferred back to the hospital or do you want to stay at home? Do you want IV antibiotics, IV fluids? All of those questions are supposed to be answered on the MOLST form. A lot of times they leave that page blank and they just do you want to be a DNR or not? You can, again, if you have your advance directive, that pairs well with that MOLST form. The difference is the MOLST is just a physician's order, okay? I want to make sure we're very clear on this. Do not resuscitate does not mean do not treat, okay? That is something people get confused. If I say I don't want CPR, that means they're just gonna leave me to die. They're not gonna take care of me. Absolutely not. We're gonna, you know, when you're in the hospital, they will take care of you all the way up to the point of your heart stopping, and then they're not going to do resuscitation, okay? So I just want you to understand they are two very different things, okay? So it is okay to have a DNR in place long before you get to the point that your heart is going to stop, okay? It's actually better because then we know, okay, this is what you want, all right? So again, having that advance directive filled out, speaking about it with your physician is your primary care, giving them a copy of it, so important. Talking to your loved ones about it. Because if you know about all this stuff, but you didn't communicate it to your family or the person who's going to be making your healthcare decisions, that's when we get into a lot of problems. Because the daughter says, but wait, I want to do this, and the son says, but I want to do this. And nobody knows what mom wanted. Okay, so if everybody knows what mom wanted, even if it's not what they would choose, there's a piece when they know, okay, I'm making the right decision because it's what they wanted, okay? Withdrawing care or switching from curative care to comfort care only. So you'll hear different terms. We're going to withdraw support. We're going to do comfort care only. That is when we say, okay, we're not going to do any more curative treatments. So we're not going to, draw a bunch of labs and see where your potassium levels are. We're not going to be replacing all these things. We're not going to do transfusions. We're not going to do antibiotics. We're just going to keep you comfortable. Okay, so that's a different level than the do not treat or do not resuscitate. Sorry, this is where we say, okay, and I can't stand this phrase, but we can't do anything anymore, right? There's nothing else we can do. You've heard that, right? There's so much we can do to keep someone comfortable. Okay, so again, that doesn't mean you're not going to be treated or not cared for. You're still going to be cared for, just in a symptom management way, not a curative way. Okay. Pain management at the end of life. Okay, this is another thing that people have questions about a lot. Okay, so again, I'm going to go back to reading the really long, complicated thing that's in the ethical and religious directives. So, patients should be kept as free of pain as possible so that they may die comfortably, with dignity, and in the place that they wish to die. Since a person has the right to prepare for his or her death while fully conscious, he or she should not be deprived of consciousness without a compelling reason. Medicines capable of alleviating or suppressing pain may be given to a dying person, even if this therapy may indirectly shorten the person's life, so long as the intent is not to hasten death. Patients experiencing suffering that cannot be alleviated should be helped to appreciate the Christian meaning of redemptive suffering. Okay, so I'm going to break that down. Okay, so people should be allowed to be as free from pain as possible. Pain it's so taxing on the body. I'm sure everybody in here has an ache and pain, and it distracts you, right? You go, oh, I want to do this thing, but wow, this really hurts, So people have the right to die with the dignity of not suffering, not being miserable, not being in pain, and where they want to die, okay? Some people want to die at home. Some people don't want to die at home. They don't want their loved one to remember that I died in this bedroom, they want to be somewhere else. We want people to, again, be able to receive the sacrament of the sick and to be able to receive, extreme unction and all of that, and to be able to receive the Eucharist if possible, go to confession, do those things. Please do not wait till the last minute to call the priest. Right, Father Larry?
Amen.
Amen. All right. So it's okay if you call and they receive the sacrament of the sick weeks to days ahead. It still counts. It's okay. All right. So we don't have to wait till, do you think that it's 2 hours left? Do you think we should call the priest? He could be in the middle of something, so maybe we should have called earlier. Okay. But again, when the person is awake and conscious and able to alleviate themselves with the sacrament of reconciliation, it's just so much better for them. And then nobody's worrying about, do we have the timing right, okay? I want to talk about the part where it says that we don't want to, that we're giving them medication even if it could hasten their death. Studies are actually now showing that if we alleviate patients' pain, that their life is actually longer because it takes the stress off of their heart, it takes the stress off of their body, they're able to be more relaxed. They actually live longer. So what is the most common side effect of narcotics?
Sleep.
Respiratory depression, sleeping. Guess what it is?
Constipation.
Ding! Constipation is the most common side effect of narcotics. Okay? So, it is not that you're going to die if we give you a dose of morphine. It is not that you're going to sleep. Okay? If you give me, who just, I survive on just my regular old allergy medicine and stuff, if you give me a bunch of morphine, I absolutely am going to fall asleep. Okay? But if somebody has been needing it on a regular basis, okay, and again, it's been being given in a medically appropriate dose and and way, they might be sleepy for 24, maybe 48 hours, but their body acclimates to it. Okay, anybody who's had chronic pain knows that you can be on a narcotic for a long period of time and be functioning and doing your day-to-day work because your body develops what's called a physical tolerance to that. Okay. So it usually takes 24 to 48 hours for a person to acclimate. But then once they do, in general, that's not a problem anymore. Okay, so it's a very temporary side effect. Okay, and again, I want to emphasize that point that when we can have someone's symptoms managed, their life expectancy is the same or longer than if they hadn't received any.
Are you saying, if at end of life you're giving somebody morphine, it doesn't necessarily enhance? So I'm talking about morphine specifically increase, shorten the life.
Correct. In general, what we're saying, if you're giving morphine in medically appropriate doses, which is what would be given, then it does not shorten their lifespan. And because again, I talked about like in that hours to days before death, that dying process started occurring right weeks or months beforehand. It's already happening. The person is already sleeping more, less alert, closer and closer to unconsciousness. And so the morphine is actually not making the difference. So, yep, it does not so it will not shorten their lifespan. It will be making them more comfortable for the time that they have left.
I think maybe the confusion is you hear two different things. You
Correct.
actually had medical personnel say
Yep.
this is going to increase.
Correct. And most of the time it's due to lack of understanding.
Yeah, so this is
So,
the problem.
so I have given people, I will say this one freaked me out, and I called the doctor and I rechecked the math, and we called the pharmacist to clarify that we were doing the math right. And this is a woman who was, she was young, she was 42 with horrible breast cancer and, bone disease everywhere, and was in tons of pain and had been for a long time. She was on we call a pain pump. She was on 42 milligrams of morphine an hour, and she's still getting up and walking around and going to the bathroom. Okay, so it is, and if you're giving it in a medically appropriate for that person, if you gave me 42 milligrams of morphine right now, I would fall over and I would die of respiratory depression because my body's not used to that, right? So I wouldn't give that to a person who I didn't know was already getting, wasn't already in a lot of pain, had been for a while, and had been giving it, had been receiving it and was used to it, okay? So, but an oral dose of 5 milligrams or 10 milligrams of morphine is very appropriate for somebody who is having pain or shortness of breath. It is, and it lasts about 3 to 4 hours, and then they will wind up having a little more pain, and it'll come back, and then you give them another dose, and it's okay. So yes, that is, but unfortunately with the opioid crisis that we're having in the country, doctors are now so scared of giving opioids, okay? They're also, I'm 3 slides from now, but that's okay, that one will be shorter. When we get, the other thing that we can do, that we use a lot is lorazepam, or an anti-anxiety medication. And if you pair the morphine with the Ativan, because if you think about it, when you're in pain, what happens? You get tense, right? Okay? And when you're tense, you have more pain. So if you can help the person to relax and control their pain, you actually, although you're using 2 medications, it has like a symbiotic effect, and you actually can use less medication overall than if you were using just one or the other. Which, the way residents are being taught now, they're saying you can't combine them, you're gonna kill them. No, that is just, it's just not accurate in my experience. It is not an accurate statement. So, yes.
Would you say that a lot of people misunderstand the use of the antipsychotics because people think you're giving them this huge dose, when in fact you're giving them a minute amount of the antipsychotic? It's not like they're crazy.
Correct.
But the effect of the antipsychotic with a painkiller, just like you said, makes everything good. So when you hear people get Haldol or lorazepam or something, they're like, oh my gosh, that's crazy. But it's not, right? Correct.
So we come based on the person's symptoms. Again, when I was talking earlier about that terminal restlessness stage, right? When somebody's, they know that something in their body is not working and they gotta get out, and they're up and down and up and down and up and down. And you can't talk to them, you can't talk them out of this symptom. There's nothing you can do to make them feel better. We give, so in a psych hospital, you would give Haldol, which is, again, it's categorized, if you Google it, it's an antipsychotic. If you're giving 5 to 10 milligrams of that, yes, absolutely. That's what you're gonna give the psychotic person who came in the ER raging, okay? We use 0.5 to 1 milligram, and basically it just kind of helps that restlessness calm down a little bit, okay? So yes, your loved one is not psychotic. We are not trying to just sedate them. We're giving a very small dose to just bring that down, to help that restlessness ease. And then you're using a little bit of the morphine or the Ativan to help them to relax, to resolve any deep breathing difficulties, and any pain. Because sometimes that agitation is caused from pain. Sometimes it's caused from a full bladder. Like we go through and do all the investigating to figure out what is the source of the problem. And if we investigate and there's no other sources, then it's this terminal agitation that we then medicate. Okay? Yes.
I've never had morphine, but I just want to go on record. If I'm dying, everybody, I want as much morphine as I can take. I want the lorazepam and the Ativan or whatever the heck. I want the whole shooting match.
That sounds good. All right.
Can I say something real quick on this whole thing? We were talking at the break, and my dad died in the ICU. My mother died under hospice care. So again, the hospice care was wonderful. I think it was much preferable than the way my dad crossed into eternity. But I was with them both at the end. But one thing I will say about hospice care when it's in home, it's nice if you can get it in Gilchrist. But when it's home, there's a lot of responsibility. I don't know if this is something you're just going to get to, but man, the family, you end up becoming the nurse. The night before my mom died, I'm up all night, in there, 3 in the morning. She's restless. I'm going to the fridge, getting the Ativan or whatever it is. I don't know what I'm doing. I mean, they gave me instruction. I had a general idea what I was doing, so I was using my common sense, but there's no one to ask. It's 3 in the morning. I'm making decisions. My mom got on my case because I pushed her cannula into her nose. My last word from my mom was she was giving me a hard time.
That seems accurate. So your mom was being your mom. That sounds, yeah. So yes, so there is a lot of responsibility on the family when we go home, and that's why we're going to talk about different levels of care and what is the right place for a person to be. So we're going to tackle that too. All right, so how do we know someone's in pain if they can't tell us? That's something that I have so many people tell me they're worried about, okay? This is, again, long thing. This is a nursing tool we use all the time to assess for patients for pain. This was developed from people who had advanced dementia, who couldn't tell us that they were in pain. Lots of research went into this, and this is an amazing tool that when I started hospice, I was like, where has this been my whole career? Because I knew somebody didn't look comfortable, but I didn't know how to kind of quantify it. So look at 5 different categories. Look at their breathing. How are they breathing? Is the breathing comfortable? Is it fast and rapid, and are they having any trouble and labored and using any muscles to help them breathe? Is it noisy and labored? Okay, you know when you go to the doctor and they say on a scale of 0 to 10 what number is your pain? Okay, that we're going to add these numbers up and get a number between 0 and 10. Okay, so if your breathing's normal, like all of us here in the room, it's a 0. If you're starting to work a little bit, it's a 1. If you're, you know, that's a 2. Okay. Negative vocalization is the person just calm and not talking, or they're talking pleasantly and everything's fine. That's a 0. If they're starting to, that's a 1. If they're yelling out and crying, I had somebody the other night, I was telling you guys last night, I kept going, Edward, Edward. She kept calling out. She wasn't necessarily in pain, but I knew she was uncomfortable. She's calling for her husband who's not there. So it was a sign to me that she was in distress. Okay. Facial expression or body language. Are you're just hanging out and you're fine? Or are you sad? Or is there like a little furrow in the brow? Or is there a full-on facial grimace, like, oh, I can't take it, you know? And are you, like I walk in and somebody's got this and they're gripping the side rails. Bet you're a little uncomfortable, huh? Okay. And then are they able to be consoled? So do they need any consolation? Are they calm and they're fine? Or are you able to talk and redirect them and talk to them, and you can just see their countenance kind of change while you're talking? Or no matter what you do and what you say, there's nothing you can do to make them look any better, okay? So anyway, if you have all of these, it's a 10. If you have all of these, it's a 5. Usually it's a combination of one or the other, okay? So again, just the teams that are caring for your loved one have ways to quantify the person's discomfort. So again, we don't know if it's pain per se. It could be pain, it could be shortness of breath, it could be that terminal restlessness, it could be, just discomfort of some kind, okay? And so when somebody can't give us like, oh, my back hurts and it's an aching, throbbing pain on and it's a 6 out of 10. When the person's no longer able to do that, we can let their body tell us that they're not comfortable, okay? So we can use that to then say, all right, given this, they're a 4, so I'm gonna give them maybe a moderate dose of pain medication. Whereas if I go in and, they're screaming, gripping the side rails and kicking and flailing, that would be a 10, and I'm going to give them a higher dose of pain medication. Does that make sense? Okay. All right, so here we're gonna go over the myths of narcotics, which we might have already talked about some of these. Okay, if I give them the pain medicine, they're gonna die, right? Everybody's heard of somebody who they went to hospice and they gave her morphine and she died, right? I mean, I'm sure most of you have heard somebody say that story. Well, you don't get to hospice by accident, okay? You have to have not 1, but 2 physicians certify that you have a terminal illness and they anticipate your life expectancy to be 6 months or less. So I hate to tell you this, you were already dying before you got to hospice, okay? Sometimes people get to somewhere where, they were in a high intensity medical environment. They then, again, if they think it's a very short period of time, like hours to days, they often will bring the person to a facility like mine, rather than, because we might not have enough time to get all the equipment set up at home and get everything in place before the person dies, so they want to just get them somewhere where it's already there. So in those cases, sometimes they were dying, they were within minutes to hours of death anyway. And so when they got the medicine, they just finally relaxed and were able to let go, and they died, okay? So again, going back to the morphine did not cause the death, the dying process was happening. There is always a last dose of morphine or Dilaudid or whatever narcotic or opioid or anti-anxiety medicine, whatever. There will always be a last dose. If you're the family member who is at home caring for someone and you are giving a dose of medication, the dose that you gave them, if it's the last dose before they died, you did not kill your loved one, okay? You did not give them morphine and then they died. They were dying, you gave them medication to alleviate a symptom, and then they died, okay? I hope everyone can hear that, okay? The dying process was already happening. You had the privilege of keeping your loved one comfortable at the end of their life, okay? That's a really important take home. All right, next one, let's see. She takes pain medicine, she'll fall asleep and not wake back up. Anybody heard that one? I do, I hear it all the time because people tell me. So again, I talked about this already. Most people acclimate to the pain medication within 24 to 48 hours, okay? Occasionally it does happen because, again, someone is already in the dying process and they're so far in that dying process that their mentation and their consciousness was already leaving anyway, okay? And so that was happening. Okay. And again, going back to those ethical principles, right? What was your intention of giving the medication? You are giving it beneficence. You're giving it for a good, to alleviate a painful symptom. Your intent was not to have someone die. Your intent was to make them comfortable, okay? So just hammering that point home more than a little bit, okay? All right, next one. If she takes narcotics, she's gonna get addicted, right? Okay, so there was a study back in 1992, which doesn't feel that long ago, but apparently it was, that reported that there were 550 cancer patients and over a total of 22,000 treatment days. Okay, so among these 550 patients, there were a total of 22,000 days that they tracked these people. And there was one case of addiction. Okay, that's a really low percentage. That's way lower than the general population. Okay, so the way your pain receptors work, say you got a nerve coming in, you got the little synapses that are gonna transmit the pain signal to the next nerve up to the brain. The narcotics work in that, what's called the synaptic joint. And so they basically block the pain signal from getting through, okay? So when someone is in a lot of pain, you have to then fill those synapses with the opioid in order to stop that signal from getting through. If you're in a lot of pain, it takes a lot of pain medicine to actually fully block that impulse. If you're not in any pain and you take the same dose of medication, then you have extra because it didn't need to be there to block anything, and that's when people get high, okay? So people who are in a lot of pain, all of the medication gets used up in these synapses, okay? They can still have the side effects of constipation, of some short-term drowsiness, etc., but they're not getting high, okay? You might like temporarily, if you get an IV and they push it all at once, but in general, that's not how it works, okay? So people aren't addicted to a feeling of being high. They're getting a relief of their symptom, okay? The other thing is if we wait until someone's pain is really bad, it actually takes more medication to to block the transmission from getting through. So if we can start to take care of someone's pain when it's at a more mild or a moderate level, again, we can use less medication, which overall is the goal, is to be able to control the symptoms as best as possible with the least amount of medication possible, okay? So don't be afraid to use them. It's my take-home message, okay? All right, so we've already talked about a lot of these medications. I'm gonna go through them again. So morphine or hydromorphone. Morphine is the most commonly used medication at the end of life. For people who have problems with their kidneys, we use hydromorphone or Dilaudid. It's not as toxic to the kidneys. And they both do the same thing, and they're used for pain or shortness of breath, okay? Morphine or opioids, they reduce the work of breathing. So the person might not have any pain, but they're having a lot of trouble breathing, and this happens a lot in our lung disease and our heart failure patients. And so we ease the work of breathing by using the narcotics, okay? Lorazepam, the anti-anxiety medication, works for anxiety. It also works for nausea in small doses, and it works for seizures, okay, in higher doses. So again, we have different doses for different symptom managements. Halidol or haloperidol is used for, again, that agitation, the restlessness. That's the antipsychotic I was telling you about earlier. Steroids are used. This is not going to bulk you up and make you look like Hulk Hogan, okay? But it's steroids, dexamethasone, and solumedrol are used also to help with shortness of breath, okay? It also, steroids work for another adjuvant to pain medication, so it helps the pain medication work better, especially in cancer pain and bone pain. Laxatives and suppositories for constipation, because poop happens. Atropine is another medication that in high doses is used in the ICU to help in the resuscitation efforts. In low doses, we use it for that, it helps to dry up the secretions in the throat, that tracheal congestion. So, and that can be given in the home as drops underneath the tongue or in an inpatient environment through your IV. So, any questions on meds? And if you're ever in the situation where you have to give these, I promise a nurse will help you. Okay. All right. Organ donors. Organ donation is another thing people have a lot of questions about. Okay.
Back up one slide.
Yeah. Back up one slide. Sure. All right. Oh yeah. Thank you. Huh. That's where my organ donation slide went. All right. So there's donors. There's a few things that can be donated if you're a living donor. Okay. So bone marrow can be given, when you're alive. One kidney, not two, because you need the other one. A partial liver transplant can be done in someone who's alive. And then one that's very common and used is umbilical cord blood can be used for the stem cells. So, and again, that's usually presented to women who are pregnant, and if they want to donate their child's cord blood, or they can save it for later if their child might ever get leukemia or something like that. So, all right. So in a deceased donor, so someone who has died, and the family and the patient had expressed wishes to be an organ donor, and the family is in agreement with that. The organs are not allowed to be removed until medical death has been determined. Seems logical, but it's a good point to make, okay? So you can't say, oh, the person might have died, we're not sure, but we're gonna go ahead and take their organs out, because then that would be causing their death. That's not okay, right? So an organ donation you have to be in a high intervention unit in an ICU in order to be able to donate your organs, because those organs need to continue to be perfused with blood and oxygen. And if you're not alive, your body can't do that. Again, like I talked about, in a low intervention death, your body starts shutting down, the blood stops perfusing the heart, the kidneys, and all that kind of stuff. So that can't be done. You would need to be in an ICU environment if you want to donate organs, okay? There can be no conflict of interest on the medical team, also for you as a person. So it has to be a free gift of self. So you can't get any compensation for it. So people you've heard people are selling organs on the black market. That's not medically acceptable or morally acceptable. That's not okay, right? It needs to be a free gift of self by either you expressing your desires ahead of time or by your family making that decision that that's what they want to do, okay? The physician who is making the determination of death in an ICU cannot be the same person who was on the transplant team, because they would have a conflict of interest, right? The transplant physician is looking at their patient who needs a lung or a liver or a heart, whereas your physician needs to be, looking after you and your best interests. So they are not allowed to be the same person, okay? It has to be a third-party physician. There are certain disease processes that make you ineligible to be an organ donor. So if you have cancer, you can't be an organ donor. You can't be a tissue donor. There's a number of disease processes that make you ineligible, and that's just because of the way diseases spread through the body. And so, okay, you know, you might have a disease in your pancreas, but it might also be in your kidney, and we don't know, and so we don't want to put a potentially cancerous kidney into someone else. Is that okay? So all those things are looked at ahead of time by the entire medical team. Give me just a second. And so there is there's a third-party team in the hospitals in Maryland, I think it's called Living Legacy, where they will look at the person's medical records. Say you're in a really bad car accident, you're unconscious, but you have, say, an organ donor on your driver's license. They will continue to treat you. That does not matter at all whatsoever, okay? You will still get the full amount of treatment. But if you have organ donor on your license, then the hospital will call the Living Legacy people. They will review your medical record ahead of time to see if you would qualify to be an organ donor, okay? Again, does not affect your medical care in any way, shape, or form, but it is, that's something that's being done in the background so that if and when you do die, and you are able to be qualified as an organ donor, they can move through the process faster, okay? Yes, question?
What if the cancer's been in remission for a long time?
Still typically not, but again, that would be a question for the Living Legacy people for them to look at. So, yes?
So, like, if you get people who are in their 80s, 90s, maybe they're generally healthy, they've never had cancer. I work with people, and
Yes.
they're kind of like, so they say, well, I'm so old, I don't think they're gonna want my organs. Do they do organ donation for people that old, or is there something that
You mean to be able to donate?
Yes.
I don't know I honestly don't know the answer to that. I can look that up and see what I find and give it to Santa for next week. All right, so what does the church say about organ donation? Because again, if we're going to do anything, we want to know that our church, we're keeping in line with what the church says. So Catholic healthcare institutions should encourage and provide that the means that whereby those who wish to do so may arrange for the donation of their organs and bodily tissue for ethically legitimate purposes. Again, you can't be selling your organs on the black market. It's not a moneymaker, okay? So they may be used for donation and research after death. We are also, it is morally acceptable to donate our body to science for research, and I think Father Larry will talk about that a little bit more next week as far as treatment of the body after death. So organs can't be removed until someone has been medically determined that they have died. In order to prevent any conflict of interest, there needs to be a third-party team. So again, church is saying, guess what? I didn't say anything the church doesn't agree with, because I'm kind of big on that. All right. Any other questions about any of that? Okay. All right. Here's my really cute slide for when we were going to take a break, but we didn't get to. All right. So it's not so bad to talk about death and dying after all, right? Okay. All right. This is what we get to look forward to, which to me, that's what all this is about, right? It's not about the end of our life. It's about we get to be with Christ at the end of this. So, all right. So that piece of paper that I gave you at the beginning, I want you to, on the flip side, after we've talked about all this stuff, I want you to write down what is it you want the end of your life to look at, like your last days, your last hours. What is important to you? What do you want that to look like? So take a few minutes to write that down. So again, we're moving from fear and what we're afraid of to now trying to picture what is it we want it to be, okay? So instead of moving away from something that we're scared of, we're moving towards something. Now, how do we put things in place and provide the support network for others to be able to help us in, okay? So, then, what questions do you ask your healthcare team? And again, I've kind of talked about this along the way. If you get a new diagnosis of something that's really scary, cancer, heart disease, lung disease, something like that, be blunt and honest with them and ask your treatment team to be blunt and honest with you, okay? I can tell you from experience, they're not going to unless you specifically tell them, okay? They're gonna dance around it because they're trying to figure out where are you at, what stage of acceptance of this process are you at, okay? So asking your doctor to say, look, I need all the information so that I can make the best decision. So even if you think it's something I don't want to hear, I still want you to tell me, okay? It might be hard, I might cry, I still need you to tell me so that I can make the best decision, okay? So what's my overall prognosis? What do people who have this, and you know, again, your physician knows your details about you and all the different things you may have going on. Given all of my circumstances, how much time do you think I have left? Okay. What does this overall disease process look like, right? So I went over some overall disease trajectories, but ask your doctor, what will this look like? If I have this treatment or surgery or whatever it is that they're recommending, what is that recovery gonna look like? How long am I gonna be in the hospital? And because they'll see, oh, well, you'll be discharged within 5 days. Okay, am I being discharged to home? Would I be discharged to a rehab facility? Would I, what would that look like, okay? What if I don't have this treatment? What would it look like, okay? So kind of like I bring my car in and they say, oh, well, you got this problem, okay? Is my car gonna keep going if I get this done? If I don't get it done, is it still gonna work? Like what would happen if I don't do this $800 repair on this $1,000 car, So like you want to know what will happen if I do it? What will happen if I don't do this? Okay? Because just because they suggest it doesn't mean you have to do it. Okay? So you want to get both sides of that so that you can have the autonomy to have informed consent. Okay? What are the most common complications? Because nothing we do is without risk, right? Every medical procedure there's always that, you sign the form saying the doctor told you all the things that could go wrong and you try to just not read any of it and, go past it, okay? When something goes wrong, we get an infection or we, wind up having to go back to the hospital or something, that's a complication. That doesn't necessarily mean it's malpractice on the case of the surgeon or a physician. It's a complication that can happen, okay? And it happens to, say this complication happens to 30% of the people. Well, that means you got a 1 in 3 chance of having that happen. Okay, so what are the most common complications? And I said, what would my prognosis be if I don't have it done? Again, I don't know if you notice, I keep saying this. Make sure your physician has a copy of your advance directives, okay, and that your family knows. Okay, all right, there's various levels of care. Some of these we're very familiar with. So in a hospital, you've got the acute care, medical surgical floor. That's like, when you go into the hospital because you have an infection and you need some antibiotics, that's the floor you're on. If you need some heart monitoring and telemetry and oxygen monitoring a little bit more, you wind up in what's called the IMC or intermediate care unit. And different hospitals have different names for them, step down, all sorts of things. And then the ICU is the highest level of care, meaning like you need a 1-to-1 nursing or a 2-to-1 nursing scenario because you're that sick and you have that many interventions that are being done that you need that kind of monitoring. Okay. On the home care side, we have a nursing aide or a companion or a personal care assistant who can come in, and help with bathing and cleaning and home health skills, things like that. Then you have skilled nursing. So say you're getting IV antibiotics at home and you need someone to come in and change your dressing and do that kind of thing and show you how to hook up your antibiotics. Because now you can do that yourself. Congratulations. Home physical therapy, occupational therapy. There's so many things that can be done at home now that we used to have to do in the hospital. Then various levels of living facilities. So you can have independent living, so a senior living apartment. Most of us are in an independent living. We live in our own home, okay? Then you have communities that you have an apartment, a bunch of other apartments that are all together in maybe in a large building or in a community that are independent living. And then you have what's called assisted living, where you're still living in your own apartment, but there's somebody on staff who can come in and help you get dressed, bring you to the dining room for breakfast, lunch, dinner, things like that, where you're not having to prepare your own meals, which that sounds heavenly. A memory care unit for people who have varying types of dementia or Parkinson's, where they're not able to keep track of things and they tend to wander. Memory care unit is a locked unit so that the person can't go somewhere that they don't need to be or can't be safe. And usually there's a garden and things like that, so you can go a bunch of different places, but you're still, a garden that is contained within the facility. So you can go inside and outside, but in a place that they can still keep track of you where you're And then a skilled nursing facility is what we would typically call a nursing home, okay? So you would have, it's a lower level of care, lower acuity of care, but people who still need care for all of their ADLs, okay? The difference between hospice and palliative care. I'm going to go through this. There are a lot of similarities. Santa, would you mind turning the lights on again? All right. So, hospice is a subset of palliative care. So, again, we're going to go do that disease trajectory over time. Okay. And there's death over here. And can't see any of that.
It's the red.
How's that?
You need a black.
I need black. Okay.
Sorry, folks, speaking of dying, I gotta do a funeral.
Did you plan that on purpose? That was good. Okay. Is that better?
Yeah.
Okay. All right. So when we're first diagnosed, okay, we have our symptoms. So in general, you had enough symptoms that took you to the doctor, right? Because you got a diagnosis. As you get sicker and sicker over time, in general, your symptoms start to get worse, and then in general, they get worse at the end. Again, not necessarily that you're in more pain or whatever, but that they require more management, okay? There's more symptoms to deal with, okay? So these are your symptoms. All right, then we have what's called curative care. So antibiotics, chemotherapy, radiation, surgeries, all of those kind of things, okay? In general, at the beginning of a disease process, you have lots of options. And then as things go on, there's fewer and fewer and fewer options. And then you wind up with no curative options at the end, okay? So these are treatments. Okay, now we have palliative care. Palliative care is symptom management, okay? So that means someone who specializes in pain management, management of shortness of breath, management of fatigue, all the symptoms that come along with these various disease processes, okay? In general, it follows the same lines as your symptoms, okay? The beginning of a diagnosis, you usually don't have all that many symptoms. You might. But in general, they can be managed pretty easily. But over time, you're going to need more and more symptom management, and so palliative care works along here, okay? So, palliative care can be brought in at any time when your regular physician says, you know what, things are just getting a little tricky, and I'm going to bring a specialist in to help you with pain or fatigue or anything like that. Just because they brought in palliative care does not mean you're going to die tomorrow, okay? People hear palliative care, they think, that's it, it's over, okay? It is not. It used to be 20 years ago. It is not anymore, okay? So it is a specialty in and of itself. Hospice comes in when the symptom burden is high and the curative options are low, okay? So this is where you would bring in hospice. Okay, so hospice specializes in symptom management when the curative options are no longer there. Okay, And you can make that choice at any point in your disease trajectory. So you could be back here, still have this many treatment options and say, I don't want to do that, so I'm going to choose hospice here. Okay? Or you can say, nope, I want to give every last single treatment possible, and so I'm going to choose hospice here in the last 2 days. I would say you won't get anywhere near as much the benefit out of hospice if you use us for just 2 days. Okay? Those long-term relationships you build with the nurse, the chaplain, the social worker, they're so much more fruitful when you didn't meet them one day and then they're coming to your house because your loved one died the next day, right? It's still a new person. So the longer you know them, the better it is. Okay? So anyway, does that make sense, the difference between palliative care and hospice? Yes.
I hope this is a good question, but I thought the palliative care line would sort of bring the symptom care line, like would reduce the symptoms, so it would dip below the symptom care.
Okay, so the symptoms are still there. The symptoms, this is the number of symptoms that are still there. So yes, the symptoms, the severity of the symptoms will go down, but the number of symptoms that are being managed is still greater.
So it's like a terminal person that they're not being cured by palliative care, they're just being managed.
So palliative care up until hospice works in conjunction with the curative care. Okay, hospice is, so when you choose hospice, there is a Medicare benefit where you have your regular Medicare benefit, or you can choose to use your hospice benefit. Once you switch over and use the hospice benefit, curative care is not covered under insurance anymore. Okay, so that's the big difference. Whereas you can use palliative care while still using your regular Medicare benefit. Okay, so these are the number of symptoms that are being managed. That doesn't mean your symptoms are bad. Okay, so this is the number of symptoms that are being managed. Okay, is that all right? Yeah. So it doesn't mean as you get closer to death, you're going to be in more and more pain. No, it means your symptoms. There's more symptoms that need to be managed. Okay. So like right now, my lower back's killing me. I need some Motrin. That's all I need. I can move on with my life. Okay. When I'm over here, I'm going to need, maybe I'm going to need some morphine and some Ativan and some Haldol, but that manages my symptoms so I can move on with my life. So there's more things that need to be managed. Okay. Doesn't mean you're miserable the whole time.
Thank you.
Okay. Yep. Okay. Does that make sense? Okay. So that goes over there. I'm getting really good at moving this stuff around. All right. Okay. So that's the difference between that. All right. So how do we make this choice? Right. That's scary and hard. Okay. So can we switch this slide off again? Thanks. So there's a great website. It's called aplaceformom.com. Kind of rhymes. Okay. I will direct you to that because honestly, they have so many articles on there. Everything from the financial to how do we make these decisions, different levels of care. So like Father Larry was talking about, when he's doing all these things and having to give the medications, whatever. If you don't have the support around you to be able to do that, then maybe an assisted living facility is a better place for you or your loved one to be. And that is, so again, looking at the entire picture with your family to find out where is the best place and physical setting for your end of life to occur. Okay? Talking with other people who have done this before, with a loved one or a spouse or a parent or a child or whatever, talking to them and asking what they did, what were you glad you did, what if you could change one thing about the experience, what would it be? Things like that. Ask those questions of the other people, right? We have saints that we ask for their intercession all the time because they've gone through things that we're going through now. Do the same thing with our church here, our community. We're not meant to do this alone. We have each other. Okay? There is no one right answer. I can't stand up here and tell you everybody should do this. Okay? It doesn't exist. Every person's situation is unique. I want you to know you take this information, you make the best decision you can with the information you have at the time. Okay? Whatever decisions you make or your family makes, you're making those decisions out of love. It might not be a one-time decision. You can always change it. I remember when my kids were starting kindergarten, and I remember panicking. Should I homeschool him? Should I send him to Catholic school? Should I send him to public school? What do I do? And I was freaking out because the decision was so big and overwhelming. I remember Father Mike Wilson was here at the time, and I went and talked to him, and he says, you make the best decision for your family at the time. I was, but it's not a one-time decision. He's like, next year it might be a different answer. Okay? So you might go and, you say, all right, we're going to take care of him at home. And then you get there and you went, oh my gosh, this is so much more than I thought it was going to be. I'm overwhelmed. I can't do this. Okay. So now the circumstances have changed. You have a better understanding of what you're dealing with. And I say, okay, we need to either bring in some help to help us, private pay, some extra, aides and stuff to come help us. Or we need to, look into assisted living facilities or skilled nursing facilities, okay? It's not a one-time decision, so take that pressure off of yourself, okay? If it doesn't work, you can change it, okay? Same thing if you decide to go to a facility and you say, nope, you know what, this isn't working, I'm gonna bring them home, okay? So just remember, you made the best decision you could with the information you had at the time, okay? If you go and you start working through a decision, you make a decision, you follow through, and it's not working, you say, okay, but I didn't have this information then. Okay, now I do, and now I'm going to make a different decision. Okay. Caregiver support. Okay, have compassion on yourself. Caregiving is hard. Yeah, this is my little minion. It says, I feel like I'm already tired tomorrow. I don't know if anybody else can relate. All right. Everyone copes differently. Every single member of your family, every single one of your friends is going to cope differently than you do. Why? Because God made us unique individuals, okay? Which can be wonderful or maddening, depending on the circumstance, okay? Treat everyone with a little extra grace, right? Anticipatory grief, okay? What that is realizing the things that I'm going to lose, okay? If you're the one who's dying, you're realizing, I'm not going to be able to be at my child's wedding. Or if you're the family member, oh, my mom's not going to be at my child's wedding, or whatever. All of these things, they're hard, they're painful, right? This is, again, a loss of control and a surrender to the process and a surrender to God for the end of our life. Okay? But it is normal, okay? Everybody experiences it. It's one of the most painful things to go through as a loved one, to know ahead of time, well, that's not going to be there, one time. Okay, information dissemination. This is an exhausting part of caregiving. Everybody's being very friendly and helpful, and all these people you haven't talked to in 10 years come out of the woodwork and they want to know what's happening, right? It's exhausting, okay? It's loving, it's caring, it's great, but it is exhausting. This is a great way to have someone who says, hey, can I help? Help, all right? So when my daughter had her car accident in 2019, we used the Caring Bridge website. These are a bunch of different websites, carecalendar.org, caringbridge.org, and lotsofhelpinghands.org, okay? And it's a way to give updates on what's going on with the person. People can send messages back of love and support, which you can read at your own schedule. And it's a way to ask for help. So say I need, somebody to take them to the doctor these 3 days or whatever. You can put that on the calendar. It will send an email out to everyone that you have put on that you've sent the invitation to the care calendar for, and then they can sign up to help you, okay? It's phenomenal, okay? One of the things I always suggest for my families to do is that you spend like 3 or 4 days, write it out a list of all the things that you need to do, that you do during the course of the week. And then on another piece of paper, you write down the list of people who have offered to help. Okay, all those people who offered to help. And you know the difference between, oh, if you need anything, just let me know, versus the people who you can actually call and help, okay? Call for help. So you make a list of the things you do that other people could do. Like you need to pay your bills, you need to do, there's some specifics that only you can do. Anybody can do your laundry, anybody can clean your bathroom. So it's okay to ask for help, all right? All right, what's the least helpful thing you've ever heard when you're grieving?
It'll be okay.
It'll be okay. What else? It gets better with time. Just wait.
Offer it up.
Offer it up, yep. So we hear really dumb things, again, from very well-meaning people. What do we do when someone's grieving in order to help, okay? Grief is expected. It's natural, it's normal, okay? It's a normal reaction to a loss. There's no timeline, okay? It doesn't matter if it's been 2 days, 2 weeks, or 2 decades since you lost a loved one. Grief happens, okay? It's real. So let yourself grieve when you need to. Expressions of grief look different for everybody. What I need to do is going to be different from what you need to do. It's going to be different from what you need to do. It's different because, again, God made us unique individual people. Some people keep it all in and just need to be quiet and they withdraw and need to be alone. Other people need to talk about it all the time. Let each person grieve the way they need to grieve. Okay? It can manifest itself in many, many unexpected ways. I say the grief comes out sideways if we don't handle it, okay? And usually that in my house looks like me yelling at my husband because the kitchen is not clean enough. Because if I can't control anything else, I can control the house being clean. So we try to find control in whatever, or at least I try to find control in whichever way I can, right? There's a thing called complicated grief. There's my loved one, we had a phenomenal relationship, and they went through a very calm, beautiful, natural dying process, and that's grief. Then there's wow, we barely could talk to each other, we didn't like each other, but yet we loved each other, and the finances are a mess, and this is a mess, and this is hard, and this is hard. That's what we call complicated grief. It's just, there's a lot of stuff. So it's more than just the death that you're trying to process, it's all the other stuff, okay? Compounded grief is when you have many losses in a short period of time that you don't have time to process all of them, okay? So, if you've had multiple deaths in less than a year, that is so hard, okay? So again, give yourself the grace, give other people grace when you haven't had time to do that. How do we support someone who's grieving, okay? Show up, okay? Initially, we've got the viewing, the funeral, right? Everybody's there, everybody, to the point that it's overwhelming, okay? 6 weeks later, you're sitting by yourself at the table, eating a meal alone, and you're by yourself, okay? That's when people need extra support. So one of the things that I do, and it's really easy, technology makes this super easy now, is when someone dies, put a reminder on my phone for 6 weeks later to call that person or text the loved one. It's a simple, easy thing to do. Just text, say, hey, just checking in on you, thinking about you. Same thing around the 1-year anniversary of when the person dies, because the rest of the world has gone back to their regular life and your world is still changed. And so you need support later. So know that grief is not a problem to fix. There's no right thing you can say to your friend or your loved one that's going to make this better. It hurts. It just is. Okay? You don't have to come up with the right thing to say. So don't. Just be a listening ear, let them talk. Okay? Offer concrete help. Hey, I'm running to the grocery store. Do you need anything? And I have a friend of mine who's grieving, and I text her. She's like, oh my gosh, I could use a gallon of milk and some bananas. Sure, no problem, And what that meant to her was that she did not have to get out of her pajamas, because it was 11 and she still hadn't been able to do that yet. She didn't have to go get those 2 things and use that energy. She now had that energy to work on coping, okay? Help with childcare, lawn, if you're an outdoor person, offer to mow the lawn for them. Go with them to a grandchild's play, because you know what, my spouse isn't there to go with me anymore, Go to mass. It's nice to have somebody to sit with when you're at church, especially if that's something that you and your spouse or your parent always did together. Again, call or text, especially nights and weekends, when everybody else is busy doing their social life and you're home alone experiencing a loss. That's a really good time to check in. Invite them over to your house for a meal. Doesn't have to be fancy. It can be Tuesday meatloaf. It's fine. It's just, again, being together. Bring a meal to them. If someone has lost a spouse, bring meals in individual containers and disposable containers. Do not make them try to remember who brought what dish, okay? Disposable containers. I'm all for saving the environment, but not in this case. Okay. What not to do. Do not offer unsolicited advice. Well, when I was going through this They don't care, okay? Just don't say it. Don't offer trite phrases, again, things like, oh, it'll get better with time. No, just no. When in doubt, silence is better. It is okay to sit with somebody and be silent for 2 minutes. It's okay. You don't have to talk. And that's coming from me, okay? Don't ask prying questions about what happened. If they want to talk about the last couple weeks of that person's life, they will. If they don't, it's okay. Right? And don't try to cheer them up. Again, grief is a normal, expected reaction. You do not have to make them feel better because you can't. Right? Let them be not okay. All right. So we're getting to this is the hope at the end of this here, okay? Redemptive suffering. We have a God who has done everything that we will ever go through, okay? When we are suffering, when we are hurting, we get to not just look at the cross, but like cling to it, okay? The closer we cling to Christ on the cross in our suffering, the more we get to be like him, okay? The more he draws us to himself. So this is from Psalm 22, and this is what some people feel like at that last couple weeks. I'm poured out like water, and all my bones are out of joint. My heart is like wax. It is melted within my breast. My mouth is dried up like a potsherd, and my tongue sticks to my jaws. And you lay me in the dust of death. Okay? We get to care for a loved one just as Christ was on the cross. We get to put chapstick on their lips, moisten their tongue with a mouth swab. We get to love them just as if we can't be there when Christ was on that cross, but we can love him in his brothers and sisters at the end of their life. And it's hard and it's painful, just as it was when Mary and Mary Magdalene and John were at the foot of the cross looking up. They can't change what he's going through, but they were there with him. We get to take that and do that ourselves. We get to be with our loved ones. We get to let them be with us when it's our turn. And we get to look towards Christ on the cross. And there is hope, right? We have the resurrection. So we've spent all this time talking about death and dying, but again, remember, on the other side is the resurrection. The resurrection of our bodies, where hopefully we'll get a better one than what we got now. And Jesus will be there, hopefully waiting for us. And one day, please God, we'll get to be with him in heaven. So, thank you.